everyone. Hello, everyone, and thank you for joining today's UMB Institute for Clinical and Translational Research Enrichment Series presentation. Before we begin, I would like to start off by reminding everyone that this event is recorded. Recordings of all ICTR Enrichment Series events are posted on the ICTR website, and I will add that link in the chat. We will reserve the last 10 to 15 minutes or so for questions. It is helpful for us if you add your questions in the Zoom Q&A feature at the bottom of your screen as they come to mind. And as you leave this session, you will be redirected to a brief survey. We welcome your thoughts on how we can improve our presentations and what additional topics you are interested in hearing about in the future. So please take just a minute or two to complete the survey. Now, I have the privilege of introducing our guest speaker, Dr. Michelle Shardell. Dr. Shardell is professor and director of the Division of Biostatistics and Bioinformatics in the Department of Epidemiology and Public Health here at the University of Maryland School of Medicine, as well as the vice chair of research in epidemiology and public health and professor at the Institute of Genome Sciences. Dr. Shardell is also the co-director of the Biostatistics and Informatics Core at the Claude D. Pepper Older Americans Independence Center, as well as our director of the UMB ICTR Biostatistics Core. Please join me in welcoming Dr. Shardell in her presentation on research with real-world data, analytical challenges, and opportunities. Thank you, Dr. Shardell.
Well, thank you so much, Wanda, for that wonderful introduction. And thanks to all of you for joining us at the lunchtime hour today. So this is actually two projects that I'm going to present. And I'm going to also give you a little bit of information about how ICTR can be a resource for you for data to do these kinds of projects. So my first project, if my screen wants to advance, there we go, is one where we're looking at the relationship between cognitive function and physical recovery after hip fracture. And we're dealing with a particular challenge called informative observation times using a real-world data set called the US Medicare Minimum Data Set. And I've assembled a couple of smart friends as co-authors who contributed to this project. So the problem that motivated this project is that physical recovery after hip fracture is well known to be very slow and incomplete, where about half of folks who fracture a hip have not recovered 6 months after hospital discharge. And in particular, if we're looking at subgroups of patients who experience a hip fracture who have an additional comorbidity, particularly those with Alzheimer's disease, they tend to be understudied. They tend to be subgroups that are rather heterogeneous. And within these different heterogeneous subgroups, the factors related to their physical recovery are generally unknown, but are important to know because they can inform personalized care plans. And in this case, we're particularly interested in their cognitive functional performance because it may fluctuate over time during this recovery period. And even among folks who have Alzheimer's disease, it could be very heterogeneous. So the question that we wanted to answer was, what is the relationship between post-fracture cognitive function and physical function among older adults with Alzheimer's disease? Now, we could do a large primary data collection study, and we are in the right place to do that. Many of you may be familiar with the Baltimore HIP studies, which have been going on for almost 40 years. However, a large longitudinal study focused specifically on patients with Alzheimer's disease would be too resource intensive for our purposes. So our solution was to look at what kind of real world data are available to us. The challenge is that any kind of analysis using real world data is tricky because these are data, such as administrative claims data, electronic health hospital records, or registry data that are generally originally collected for purposes other than research. And so the downstream analysis tends to be tricky. It's tricky for a variety of reasons. But we're going to focus specifically on one of the challenges, which is how you would handle missing data when you're using real-world data for your research. So in order to understand why this is hard, it's helpful to understand what a real-world data set isn't. And so here we just sort of have a canonical example of an epidemiologic study that has a lot of features that a real-world data set does not. In particular, we have a single recruitment time or single recruitment window. We have one recruitment cohort. We have follow-up time scheduled, well, in these pre-scheduled waves. And so essentially what we're doing is we're taking time, which at its core is something continuous, and just sort of divvying it up into these discrete intervals. And it turns out that makes missing data handling a lot easier. So for example, if someone, doesn't show up for their year 3 visit, or maybe they do show up, but, they don't, provide a blood sample or answer the question that you're interested in, it's very clear to folks that this represents missing data. Now, let's contrast that with what happens in a real-world data set. And again, here's a canonical example. Let's say we're focused on, events happening between 2017 and 2022. We have our first person, maybe they enter our data set. In our case, maybe it's because they've had a hip fracture, and they're followed for a certain period of time, and then they're done. Then we have a few more people, and they're not necessarily enrolled at the same time because their enrollment is dictated by an event happening, not our recruitment window, and so on and so forth. So we see that not everyone enters the study at the same time. Not everyone is followed up or scheduled to be followed up for the same amount of time. And then if we look at their observations, they're not at these nice, neat, pre-scheduled common windows for every single person. There's a very person-specific schedule. We notice different frequencies, even among folks who have similar frequencies. Some of those observations are front-loaded, some of them are back-loaded, but there's no kind of pre-scheduled rhyme or reason, unlike an epidemiologic study. So if we look at where those question marks are, and there's no observation there or no assessment, does it really make sense to think of that as missing data the same way we would if we were dealing with an epidemiologic study? Because if we're thinking of all the points along those lines where there's no assessment, there could essentially be infinite amount of times with missing data. And so the crux here is that unlike an epidemiologic study, we're not taking time and divvying it up into discrete intervals. We're keeping it as something continuous. And it turns out that makes it challenging to even conceptualize missing data. It's not really as clearly defined here. And that's because we have this different observation timing, not just is there an observation, yes, no. And because of that difference in frequencies, that's what may lead to the bias. And so the title mentioned informative observation times. That's what we mean, that the type of people who might be observed at different frequencies may be different from the type of people who are observed at a different frequency. And some folks might be overrepresented in your data set. Some folks might be underrepresented in your data set. So as a case study for this kind of problem, we're going to be using data from the US Medicare minimum data set. And some of you who've worked with Medicare data are probably familiar with this. Some of you who have not. What this is, it's a standardized clinical assessment tool that's administered by the Center for Medicare and Medicaid Services. It takes place in certified nursing homes as well as skilled nursing facilities. There are some stipulations on the frequencies. So even though it's not the same for each person, there is a stipulation that the maximum interval between assessments needs to be 3 months for long-term residents. And it's also required at major changes in health status. So when we see that, then it's sort of a, kind of red alarm that there's going to be informative observation times, because this means that the type of people who have more observations are probably the type of people who have more changes in health. When we're looking at the specific data set that we're working on for this project, we have a little over 9,500 Medicare beneficiaries aged 65 years and older who've had a previous diagnosis of Alzheimer's disease and who are recovering from a hip fracture between the years 2017 and 2022. And among these participants, we have over 40,000 assessments. And we're looking at assessments over a 180-day interval. So this is about 6 months, and this is informed by some of the epidemiologic data about hip fracture that tends to be an important interval for recovery. And just to give you a sense of how much variability there is in the number of observations, the median was 4, but it ranged from 1 to 17 over this time period. And if we're looking at, how the length of time of follow-up, the median is about 53 days, and that interquartile range, so that middle 50%, was from 24 to 112 days. So if we're looking at our characteristics, we see generally what we would expect to see if we're looking at a cohort of individuals who fractured a hip, where the vast majority are female sex. The vast majority are what we would refer to as the oldest old, so over 85 years. For purposes of our analysis, our outcome variable is something called a Barthel score that measures physical function, and it looks at activities of daily living. At baseline, the median was about 15, and compare that to the range, which goes from 0 to 90, where higher scores indicate better functioning. What we're using as our time exposure variable is something called the BIMS, the brief interview for mental status. And bear in mind that all of our participants have a previous diagnosis of Alzheimer's disease. And so even though this variable ranges from 0 to 15, where higher scores indicate better cognitive functioning, our median was still around a 9, and there was a wide range in that middle 50% from 4 to 13. So this underscores how this group, even though they have Alzheimer's disease, they're very heterogeneous with respect to their cognitive function, even at baseline. Most folks have some comorbidity. As a proxy for socioeconomic status, we have Medicaid eligibility, so there's maybe a fifth. And then we also have hospital size as a variable we want to control for. So I'm a statistician. I give myself 1 or 2 what I refer to as gratuitous Greek letter slides for presentation. If these are not interesting to you, I will not be offended if you use this time to check your messages. But if you're someone who kind of likes to know what's happening under the hood, you're welcome to follow along. So the secret sauce for how we're going to deal with these informative observation times is something that we refer to as a joint model. And we call it a joint model because we're essentially fitting 2 models at the same time. One for the outcome, which, as I mentioned, is that Barthel score as a measure of physical function in this case. And then the second model is one for our observation or assessment process. And that's because we're concerned that those observation times are informative. So that first model at the top, that's our outcome model. And if you look at it closely, it has some features that seem pretty similar to, like your garden variety linear mixed model. We have the expected value of our outcome of interest as a function of covariates and our regression coefficients. But where things may look a little bit different is I'm not pre-specifying how my outcome changes over time. I'm allowing that to be sort of a non-parametric component. And for this reason, it's referred to as a partial linear model rather than a linear model. I did mention that this is similar to a mixed effects model. And so these V's represent our random effect, and I'm allowing their slope to also be a non-specified function of time. Now, another term for this kind of model is a shared parameter model. And that's because our second model, our observation model, is sharing a random effect with our outcome model. And so our observation model, if you've taken like time to event analysis courses or survival analysis, this might look a little familiar to you, where this looks a lot like a proportional hazards model. So when we're being more general and we're talking about an outcome that can recur, such as an observation or an assessment. Instead of using the term hazard for the kind of rate we're looking at, the term that you'll often see in the literature is that it's an intensity. So what we're saying is we have a proportional intensity model that's a function of the same covariates, but it's a lot like, like your garden variety proportional hazards model. And what this random effect is doing is it's playing this role of sort of an unmeasured participant level factor that might be explaining why the observation process might be related to your outcome process as our strategy for addressing our informative observation times. So a good side effect of fitting this kind of model is that it forces us to estimate our cumulative visit frequency over time, which I wouldn't have been able to do, or I probably wouldn't have thought to do if I was just doing my garden variety linear mixed model. And so that it allowed us to get some additional results. So if we look at this figure, our x-axis is time, and our y-axis, or I guess this is another Greek letter slide, you could interpret that as sort of your cumulative frequency of observations. And when I first looked at this graph, I realized, and I looked at some other diagnostics to gut check myself on this, is that it looked like there was a little bit of an inflection point where just sort of the pattern seemed to change around 100 days. And I thought, this is just too much of a coincidence that it's this nice, neat pivot right at 100 days. And so I emailed one of my co-authors, Jason Falvey, who has a lot more experience with Medicare data than I did. And he emails me back and says, well, of course you see a big change at 100 days. Per Medicare policy, that is the end of their Medicare Part A skilled nursing facility benefit. So a lot of people, unless they're in long-term care, they're going to be discharged at that point. So the type of people that you see after 100 days is going to be a little bit different than the group that you see within 100 days. And so bearing this in mind, we essentially fit two sets of models. So our original one, where we were looking at our original 6 months. So we wanted to see what happened when we compared our new joint model to just our garden variety linear mix model. And although our overall conclusions about, higher cognitive function being associated with higher physical function, that held, excuse me, regardless of what model we fit, we noticed that the strength of the association was a lot stronger using our new joint model as opposed to the garden variety linear mix model. And just to get a sense of how this policy would impact our findings, we did an additional analysis where we limited our follow-up to just 100 days, and we found even more of a divergence in terms of the strength of the association, where looking at our new model, the magnitude was almost twice as big as what we saw when looking at our linear mixed model, just because we were able to tap into some of these unmeasured factors that might be influencing our observation times. So take-home message for this project is that working with real-world data are challenging. Looking at our specific case study, we saw that cognitive function after hip fracture among those with Alzheimer's disease we saw that was very heterogeneous, even at baseline, and not surprisingly better cognitive function related to better physical function after fracture. We also noticed that working with this minimum data set demonstrated one of the benefits of our proposed joint model, in the sense that I didn't have to explicitly model that policy about the skilled nursing benefit, but our model was flexible enough that it detected the policy, and having detected the policy, that facilitated this nice communication between the analytic side and the subject matter clinical side, which often doesn't happen if things are left in a black box. So we do have some ideas on how to expand this work on a more technical side, looking at, in a time varying coefficients for the covariates that we care about, in addition to the intercepts. We also want to look at other types of outcomes, not just continuous outcomes, and to explicitly handle terminal events such as mortality. So switching gears from that project, we have another project that also involves the Medicare data. And rather than more of an inferential project, this one is more of a prediction project where we wanted to look at days at home after hip fracture discharge among older adults. And we explicitly wanted to consider this as a case study on what are some mitigation strategies to address a concept known as digital ageism using a general class of approaches called fair artificial intelligence. So in this case, I assembled an even bigger group of smart friends who in my head are sort of like the 92, 93 bulls, given their various strengths that they brought to this project. So the problem in this case is that older adults, a plurality of them tend to prefer to age in place, age in their home rather than an institution. And this would manifest among folks who had a hip fracture as access to home-based healthcare after their discharge from the hospital after a hip fracture. Problem is there are many barriers to home-based care, such as access to caregivers and other resources. And so our thinking here was that if we can accurately predict post-fracture days at home, and we're going to abbreviate that as DAH, that can help with both risk stratification and resource allocation plans. And this could be helpful for caregivers as well as healthcare providers. So then our question here was, how can we develop and validate a predictive AI algorithm for post-fracture 6-month days at home? But we wanted to be mindful that when developing and validating an AI algorithm, there's different sources of bias that can emerge. And since we're generally concerned about the older adult experience, we were concerned about a concept known as digital ageism that can emerge across the AI pipeline. So this term digital ageism is relatively new. I first saw it published in the Gerontologist a couple of years ago. And it generally refers to a collection of age biases in technology, including but not limited to AI, that can emerge across the stages in the technology and AI pipeline or life cycle. So in order to think about this, we first had to think about, okay, what are the stages of the AI pipeline that we're going to address here? And the ones that are most commonly delineated are the question formulation first, followed by data collection, then data pre-processing, and then lastly, model development and validation. There's also concern about, implementation, which we'll discuss later. And once you get to the end, sometimes that requires folks to retool and start from the beginning. So thinking about these different stages of the AI pipeline, we had to sit down and think about where digital ageism can emerge. So for question formulation, that can emerge by completely ignoring the fact that the ultimate goal is to deploy the AI algorithm in older adults, or maybe not consider how their needs and preferences may differ. And that includes, what kind of outcomes they care about. And so that was one of the reasons why we looked specifically at the days at home outcome, because we knew it was a patient-centered outcome that tended to be preferred by older adults. When we look at the data collection phase, how can digital ageism emerge here? One reason is if you have just a lack of representation of older adults in the study sample that will ultimately be used to train your AI. One that doesn't get as much attention is just the systematic ageism in the data generation. And this can emerge in real world data in terms of who gets what healthcare and how these decisions are made. Age may play a role in a way that's biased. And so bearing that in mind, can be helpful if down the pipeline, we see results that are counterintuitive. Understanding how the data are generated can often help explain those two counterintuitive findings. What about data pre-processing? Well, sometimes with the best of intentions, folks will operationalize their variables in a way that are either, like normed by age or adjusted for age. And this could, in some ways, create more biases than they solve. I think an example of this, looking at other demographic characteristics that was really high profile, is the equations used to operationalize estimated I always mispronounce this, EGFR, glomerular filtration rate, because those are often functions of both sex, age, and race. And there was a high profile publication in the New England Journal calling for not using race in those equations. And I think we're seeing more attention to the use of age and sex and other demographic characteristics in these types of variable definitions. So this may be a place where we need to bear in mind age coming into play. The other one is, how are we handling attrition bias, such as truncation by death in this case? Because not everyone may live the same amount of time after a hip fracture. So you'll notice these first three, they're not really technical at all. They're more related to the epidemiology side of things. But it's important to consider that because their biases may propagate once you get into the more technical side of things. The last one, the model development and validation, is a bit more technical. And so things we have to bear in mind might be demographic or contextual shifts about, about the changes in policy, protocol, practices, and patients in the data that are used to model your AI. If those change over time, then that may lead to decay in model performance. The other one that we're going to consider more carefully is oftentimes when developing an AI, we look at these different metrics about how the fit of the model or the model performance is. And oftentimes those are overall assessments. But if you have small subgroups, you could have a phenomenon where the model performs well overall, but it doesn't fit well for certain subgroups. And so there may be systematic or systemic biases in those different kinds of subgroups. And we'll see an example of that here. So let's talk about the mitigation strategies. So for the question formulation, oftentimes one of the complaints that I hear is that the AI scientists just throw a bunch of data into a model without really considering the domain expertise. In order to prevent that from happening, the reason why we had such a big all-star team is we needed to have the multiple disciplines with the diverse domain expertise to make sure we weren't doing that. And that ended up being very helpful. And then, as mentioned, we used a patient-centered outcome that we knew was important for older adults. For data collection, we, as mentioned before, we're leveraging data from Medicare, which is generally considered a representative sample of Medicare beneficiaries. These are the fee-for-service beneficiaries that cover the vast majority. In this study, we had over 70,000 Medicare fee-for-service beneficiaries who experienced a hip fracture between 2010 and 2017. Between 2010 and 2016, this was a 5% sample of Medicare beneficiaries. In 2017, it was a 20% random sample, and I'll describe how we address that. In order to try to wrap our brain around areas where systemic ageism may come into play for data generation, we created a directed acyclic graph to help us think through some of this. And this was more just to plan ahead. So this is what our directed acyclic graph looked like, where we wanted to consider the factors both measured and unmeasured in the Medicare data that might influence post-fracture days at home. So we had a variety of, demographic characteristics, hospital characteristics, health characteristics. And then other unmeasured characteristics, such as, the access to the caregiver, which we mentioned earlier. If one does not have that, that would be a barrier to optimizing days at home, and other sort of lifestyle characteristics, which may play a role in comorbidities and other post-fracture outcomes. So when we looked at data pre-processing, we wanted to make sure we operationalized all our variables in the same way. When we looked at 6 months days at home, we encoded mortality in such a way that any day after death would be given a 0 for days at home. If we were interested in how many days in healthcare versus how many days at home, that would not be the ideal approach. But because we wanted to compare days at home versus any other time, it seemed like an appropriate approach for here. And we wanted to preserve our baseline generalizability, which was our rationale for that approach. For our model development and validation, we used 1 training set and 2 validation data sets to look into generalizability and data shift. And I'll talk about those in details. And we used a fair regression approach to deal with these small subgroups that we were concerned might not be adequately estimated or accurately estimated as compared to the majority. And I'll talk about that in some detail too. So in terms of the model development and validation, so our training data set comprised 70% random sample between 2010 and 2016. And if you recall, that's where we had our 5% random samples. And we took 50 replicates just to avoid having that single sample just have chance imbalances. And so our first validation data set, we referred to this as our internal cross-validation. And this comprised the remaining 30% of the data from 2010 to 2016 that were not selected into our training data. And what this did is it allowed us to assess performance in similar data and avoid overfitting. Whereas for our validation data set number 2, we referred to this as our external validation or testing data set. And we used all the observations from 2017. And our goal here was to see how this performed, to see if we were robust to data shift. So differences in, underlying context from 2010 to 2016 versus 2017. And we wanted to be mindful of the potential secular changes in what we refer to as our 4 Ps of the data context. So differences in the types of participants or patients who might be fracturing later versus earlier. Differences in policies, and this could refer to, healthcare payment policies in Medicare, or differences in protocols and practices in terms of, how healthcare is delivered at the patient level. So not knowing the specifics of what those are to model, we just wanted to look at secular changes to make sure that our model performed well, regardless of those changes. Now, we're at an apparent impasse if we're concerned about algorithmic fairness. And so here's the impasse, and this has been widely published on. So one proposal is that, we should not adjust for demographic variables, or what are referred to as social variables, by CMS. And this approach is referred to as, fairness through unawareness. Like, we don't want to bias ourselves by throwing, race, gender, age, other demographic variables into our model. And this is also consistent with the CMS guidelines for risk adjustment or stratification outcome assessment. Problem with this approach is that it's been shown to just not perform well in practice. So even though the goal here is to achieve fairness, the results tend to be biased. And by biased, I just mean inaccurate. So then it becomes a situation of, okay, well, maybe we should adjust for demographic or social variables. However, this is inconsistent with the guidelines from CMS for risk adjustment or stratification. And the concern also is that decisions might be made if these kind of models are used for clinical decision support, if it becomes explicit functions of demographic or social variables as opposed to health. So this could result in a different kind of biased AI. In our particular case study, our concern about digital ageism is that it's been well shown in multiple studies that male patients who fracture, they tend to be younger and sicker than other patients at the time of fracture. So this becomes sort of a small group that's different from the majority that we were concerned about our model not fitting well. So we have another gratuitous Greek letter slide. And this is going to show how we resolve our impasse. And in contrast through fairness, through unawareness, we're going to use an approach that's been called fairness through awareness. So what we want to fit looks like, just a garden variety linear regression equation. And if you're familiar with garden variety linear regression, then you know that the objective is, to fit through ordinary least squares. And by ordinary least squares, we mean find the values of the betas that make the squared residuals as small as possible. So that's the garden variety. And that would be an example, if we didn't have any demographics in our X's, this would be fairness through unawareness. So what we're going to do is fairness through awareness using an alternative approach known as average constrained regression. And the idea here is to say, okay, we still want to minimize our squared residuals, but we want to bake into the cake an additional constraint. And the constraint that we want to bake in is one where we ensure that the average of the residuals among that small group that we were concerned about being unfair to, in this case, male patients and on the younger side, so in this case, ages 65 to 74 years equals 0. So if I just did ordinary least squares, that would mean that the average of my residuals for everyone is set to 0. What I'm saying is we want it to be that way for the subgroup in particular, because it could be that way for everyone, but then not for, for everyone on the aggregate in the way where the overestimates and the underestimates balance out, but it may not balance out for a specific subgroup. So looking at our data, if we look at age by sex, we do see that the younger male patients tend to be in the minority in both the 2010 to 2016 as well as the 2017. We do start to see a pattern where there's a greater proportion of male and a smaller proportion of the oldest old female over time. So we do see that pattern, which is why we wanted to make sure that we protected ourselves against data shift. So if we're looking specifically at comparing our male patients age 65 to 74 years with all the other patients, what we noticed about this group that's different is the male patients age 65 to 74 years, they had higher proportions with diabetes, higher proportion with peripheral vascular disorders and chronic pulmonary disease. They also had slightly longer hospital lengths of stay. Interestingly, they tended to have longer post-fracture stays at home, which is what we're going for. And, if we're trying to understand why, because they tended to be younger male patients, they were more likely to have a spouse at home. So in contrast, even though male patients tended to be sicker than the female patients at the time of fracture, that doesn't necessarily mean that they had higher proportions of all comorbid conditions. They had lower proportions of uncomplicated hypertension, valvular disease, and specifically hypothyroidism. So when we fit our models and we had our ordinary least squares versus our average constrained regression using both our internal cross-validation and our external validation / testing data sets. We noticed that comparing the R-squareds between OLS and ACR, the ACR R-squared tended to be lower. And so that reflects that by having that additional constraint, there is sort of a trade-off in the overall fit. But what did we get in exchange for that trade-off? So one of the metrics that we looked at for fairness was the mean residual difference comparing the male patients aged 65 to 74 years versus all their patients. And so what we would want is for this to be as close to 0 as possible. And we do see that there's a difference by about 16 days using OLS versus 11 days using the average constrained regression. Whereas when we looked at our external validation data, first thing to notice is that for our R-squared, there seemed to be less of a trade-off that we were making with respect to fit by having that additional constraint. And we also, in exchange for that trade-off, we did see an improvement in fairness where we went from a difference of negative 14 days in the residuals comparing the groups to negative 9 days. So we did achieve some improvements in fairness. So what about the specific predictors? So if we wanted to compare the specific predictors between OLS and ACR, this is sort of our top 10 biggest changing ones. We saw the largest increases tended to be the ones where there was a higher proportion with that health condition among the males aged 65 to 74-year-old. And then the largest decreases were the ones where the males tended to have the lower proportions of that health condition. The males aged 65 to 74-year-olds had the lower proportion of that health condition. Notably, biggest increase was in the complicated diabetes, and the steepest decrease was in hypothyroidism. So again, I want to reiterate that most of the strategies we use to mitigate digital ageism weren't really techie. They were more kind of epi-focused and refining our research question. And this is true for fair AI in general, even if it's for other reasons other than looking at ageism. We did see that the average constrained regression, there were some trade-offs between fit and fairness. And, when we looked at our external data, the trade-off, the gains in fairness seemed to really offset the trade-off that we made in fit, although the R-squareds in general were super not impressive. But when we looked in the literature, we saw that the fit, the R-squared, was actually pretty similar to published risk adjustment equations that have been used for healthcare payment. Now, I mentioned that there was an additional phase in the AI pipeline, and that's implementation or monitoring, which we haven't gotten to at this point. And that would be a function of what you would do upon implementation. And this would require, just a continuous reassessment and potential retraining to prevent performance decay. And although we did some validation bearing data shift in mind, that doesn't mean that data won't shift even more in the future, particularly if there are major changes in Medicare payments. So our future work is we did want to include more recent data on this and look at other relevant post-fracture outcomes. And we looked at just one set of constraints for average constrained regression, but we can also consider other small subgroups who were concerned about there being bias and include multiple constraints in our model. We do have code available using R that's up on my GitHub, which you are welcome to. So before we get to Q&A, I just wanted to quickly shift gears about how ICTR can help you access resources to do these kinds of analysis using real-world data. And I first want to give a shout out to one of our core members, Abiri, who is an associate director of our Biostat core and also a member of the Informatics core. More to the point, she's the director of the Pharmaceutical Research Computing Center, which is where we received access for these Medicare data. And I just pulled this information from the ICTR website, so don't feel like you have to scribble everything down. It's right up there. There's the link at the bottom. But there also may be some availability for some support for accessing these kinds of data. So in addition to Medicare data, you can also access other kinds of real-world data through ICTR. There's the ability to access EPIC data. However, I highly recommend, if this is of interest to you, to go to the ICTR website, look at, what kind of ducks you have to have in a row to access the EPIC data, particularly as it relates to, the IRB, the secure research environment, and or data use agreements. It's good to kind of anticipate your needs to avoid excessive back and forth in terms of requesting these kinds of data. And once again, the information on how to access these data are up on the website. I also wanted to make sure that you were aware of the kind of expertise that's available in the ICTR Biostatistics core. So I mentioned a Barry who has been really great about providing crosstalk between the biostat core and the informatics core. And so she's really knowledgeable in terms of how to work with linking real world data, such as claims, registry, EHR data, and has expertise in some of the econometric analysis methods. Jessica Brown, in addition to being the associate director of the ICTR Biostat core, is the director of CTRIC. And so she has a lot of expertise in survey methodology and how to develop and deploy surveys, as well as other skills as well. Gang has expertise in creative, innovative methods for experimental design, linear mixed models, and also has a lot of expertise and experience in computational biology and machine learning for clinical decision support. Bruce DeForge has expertise in mixed methods, which is a combination of quantitative and qualitative approaches. He also has expertise in repeated measures ANOVA, the analytical implications of community-based participatory research, and other study design skills as well. Larry Magder, who many of you may know, has also methodologic expertise in how to handle measurement error and misclassification. He understands a lot of the theory under the hood regarding null hypothesis significance testing. He also has a lot of experience in infectious disease modeling, such as transmission probabilities, as well as longitudinal data analysis. Kai Sun has a variety of applied expertise in study design, multivariate methods, difference in difference modeling, survival analysis, and competing risks, propensity score methods, and other approaches as well. And lastly, Shijun Xu. He also has expertise in mixed methods, analysis of pragmatic trials, complex mediation, moderation, structural equation modeling, survey measurement, development, step wedge designs, and other skills as well. So if you're anything like me, your favorite part of a talk is the references, because that's where you know to go to find out more. And I'd also like to acknowledge funding, the UMB ICTR, the Pharmaceutical Research Computing, especially Kathy Ryan, who kindly provided the data for us. And as mentioned earlier, I'm affiliated with our Pepper Center, so I want to acknowledge them as well. So thank you so much.
Dr. Shardell, I believe Dr. Safari would has a question. Let me see if I can.
Do I see Q&A? Well, I don't see the Q&A.
It's not in the Q&A. We just need to allow him to speak, but I am. Let me just find him on our list. There he is. Okay. Dr. Savari, I believe I think you're.
Hi,
you're unmuted.
Okay.
All right, thank you. This is Zafar. Thank you, Dr. Shardell. This was a great talk. I just have a couple of quick questions that I was just wondering. So the first project, when you use the joint model, so I'm just wondering what is the reason that the variance of the um, the effect size has increased, right? So I think it's almost like 50% more when you use the joint model compared to just just a single model. And what are the implications of that in terms of false positive rates? I mean, the detection of true effect in a real case scenario. If you
Yeah.
look at the row one versus row two.
Yeah, that's right. That's extremely observant. That one of the trade-offs that we're making here, by accounting for the potential biases from the informative observation times, is that our confidence intervals are actually much wider using the joint model as compared to using the garden variety linear mix model. And in terms of looking under the hood, and we also did a variety of simulation studies to understand the performance of these models, it really boils down to what's known as the bias variance trade-off, where the cost you pay for that additional flexibility is the increased variability. So, those are some of the trade-offs, which is why I'd be really interested to see what happens when, in addition to having the time varying coefficients for the intercept, and then for the random variable slope, what does that do to our variance if we were to have time varying coefficients for the other covariates as well? Because you just need to estimate more things. And so in my head, I always think of that as you're spreading your data out more thinly that way.
I see. Yeah, thank you. Thank you for explaining that. And my second question, may be actually irrelevant. So my apologies in advance if it's not really relevant, because I didn't quite get the problem that the differences in time for male, the smaller subgroup versus the larger subgroup. But I think my bigger, maybe like a high level question is, why not using, in these kind of situations, why not using two different models rather than, enforcing one model and imposing all those additional constraints to make sure, we are narrowing down the unfairness. Is it, what do you think? Like, is it appropriate to think about, different models for different subgroups, especially for those unfair or discriminated ones?
Yeah, and this was part of the benefit of having such a large, multidisciplinary group with different kinds of expertise. Because if you were to think about having the stratified model, which is essentially what that is, that's tantamount to, essentially fitting one model and then having interaction terms between group status and all the other predictors of interest. And so our concern there is that we were creating a situation where, for example, if this was going to be used for decision support, that your decisions would be an explicit function of someone's demographic categories. And we're also mindful about the risk stratification guidelines for CMS that specifically said don't include any kind of social variable. And so we're thinking, okay, we don't want to have our decisions be explicit functions of these variables, but we do want to bear in mind that if we're not aware of them at all, then that might lead to underperformance for certain groups. So that was the thinking, how do we overcome that catch-22?
I see. Thank you. And great presentation again.
Thank you. Any other questions?
I don't see any additional hands up or questions in the chat or the Q&A feature. So I think that concludes the questioning.
Okay, shy group.
Well, Michelle, it was great presentation. Thank you. And it really shows not only the depth and breadth of your statistical expertise, but also our core, from the ICTR core, which has been assembled to be able to address the customized needs of our investigators across our ecosystem, the 7 schools and the library, College Park and UMBC. And we're really delighted in your leadership. So thanks so much, and thanks again to Wanda, put the show on along with Rona Melendez in our office. And so thanks to everyone. And the ICTR is still here. We're still open for business, and we want to help everyone's research, whatever the mechanism is in these quite troubled times. So thanks again, everyone.
Thank you so much. Thank you for inviting me, Dr. Davis. And thank you all for attending, and have a great rest of your day.
Thank you.